Welcome to Parallax by Ankur K Al-Lamee, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur K Al-Lamee, MD, Interventional Cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur K Al-Lamee, MD.
Hello, everyone. I have the honor and pleasure of having with us on Parallax today a guest from across the seven seas, trying to sound poetic or philosophical. But I've obviously read her work, and I've been following her work, which is, has been phenomenal. I'm sure all of us have been in the field of cardiovascular medicine. And I had the honor and the privilege of actually meeting her in person at TCT this year. In San Francisco. So without much further ado, please welcome on the podcast Rasha Al-Lamee. Dr. Al-Lamee is an academic interventional cardiologist at Imperial College of London in London, United Kingdom. And again, from the entire team at Parallax, Rasha, it's our pleasure to have you on the show.
Thank you very much for having me.
We've been wanting to do this with you, and our team had identified you as one of the guests early on. It's just that it has taken us that long to schedule a conversation with you. So I'm going to just dive right in, and first of all, congratulate you on ORBITA and on other papers that you've published in the field of revascularization and stable ischemic heart disease. So before we dive into the science, just tell us a bit about yourself, about your background, and how you became the Rasha we now know. I think it would be fascinating for our audience to learn about your journey.
Okay, thank you very much. No problems. Well, it's obviously an honor to be interviewed today. So, I don't know, to talk about my journey, it sounds a bit grand, but I'm obviously an interventional cardiologist in London. I was actually born in Liverpool in the north of the UK to two parents who both have PhDs, one in maths and one in chemistry. So no doctors in my family in medicine, but doctors in academia. And I'm originally from Iraq. I basically grew up in the north of England and then studied in Oxford University, and then went on to do my clinical training. After preclinical training in Oxford, I went to University College London to do my clinical training. Then qualified as a doctor and really stayed mostly in London, but kind of travelled around the UK doing my training. And then started my interventional cardiology and general cardiology training on the Northwest London training rotation. As part of that, I obviously did interventional fellowships at the Hammersmith Hospital, which is really where my base has been for many, many years. And I also did a year's international fellowship with the great Antonio Colombo in Milan, which was kind of a fantastic time to learn about research and become a little bit more academically minded. And then after that period, I came back to the UK and not long later started planning my PhD with Justin Davies and Professor Darrell Francis, so very kind of leading academic cardiologists. And then, of course, my PhD was the ORBITA trial. So that took us 4 years. It was obviously quite an endeavour. And since that time, and since kind of the results and all the rest of it, my career path has really changed a lot. I think I always predominantly thought I was going to be mostly a clinical cardiologist and an interventional cardiologist. But over time, obviously, I became more interested in academia. And then because my PhD really got my interest stirred and has really kind of redirected me, So now my job is very much 50% academic work, 50% clinical work at Imperial College London and at Imperial NHS, and obviously focusing on stable coronary artery disease predominantly and kind of the study of ischemia and how best to diagnose and treat our patients. That's kind of the journey.
Yeah, no, thanks for taking us through the journey. It's fascinating when you've trained at phenomenal places. When I was in London last year in December for the London School of Economics program, I really wanted to take a train ride to Oxford, but it just didn't happen. Hopefully, when I'm back in June of 2020, I'll hit you up on maybe touring Oxford. It'll be phenomenal to see the place.
It's a gorgeous place. It's got a lot of history.
Yeah, I'm sure it does. So, just circling back to ORBITA, so what's really fascinating is, how you converted your PhD and project into, just a practice changing, if you will, paper, just to bring, I think, for the listenership and for the audience, I think I haven't really seen or listened to stable ischemic heart disease revascularization being, talked about with that degree of passion, obviously early on with the courage, but then I think it sort of reinvigorated a lot of the emotion and the sentiment that I think courage had brought up, early on. So what was the motivation to do a trial like ORBITA? I'm sure you'll talk a little bit about Daryl Francis here, but what led to the genesis of the ORBITA trial and your PhD?
Yeah, so the reality is, obviously in designing the trial, we had absolutely no idea it would be so controversial. We very much thought it would be a positive trial for interventional cardiology and PCI because we're all interventional cardiologists. But what kind of happened and how it came about was I came to a point in my career where I decided I wanted to do a PhD. And we were trying to work out what my PhD program would be. And in fact, I did my PhD at quite an unusual stage. In the UK, mostly people would do their PhD very much slap bang in the middle of training or around about that time. And for a variety of reasons, my PhD came towards the end of my training. And I was in the lab actually by then, kind of independently doing angioplasty, doing a PCI procedure with, in fact, Daryl Francis sitting outside being my kind of supervising consultant, but not actually in the lab with me. And having stented, and I still remember it, a kind of mid-circumflex lesion in a patient who had chest pain, I came out and kind of said, what do you think about the result? And he said, yeah, great, whatever, as kind of Carol would say. And he said, well, why did you bother to do that? And I said, well, because the patient had pain, and they had this ischemic test that was positive. And we were realising that placebo-controlled trials were really important. And he'd obviously been quite engaged with that debate and for many years had predicted that the blinded results might be quite different to the unblinded results. And so then we designed ORBITA basically. And so, I wrote the protocol along with obviously my supervisors. And then I must admit, it seemed like a quite impossible PhD program. And Daryl still says that at all phases through the years of me recruiting all these patients, he kept being kind of a bit amazed that I was still doing it because he thought I'd just give up. And when obviously when it was published and when we completed, he told me, he said, I never thought you'd actually do it. And I said, I wish you'd said that to me years ago because it was really quite a painful process. But then the results obviously were a massive surprise. And if there was anything that I can kind of tell my younger self now, it was perhaps not to be so quite so naive about research. I don't think we'd ever imagined that the impact of the research would be quite as it was. To be honest, we hadn't really thought about it being negative. We certainly hadn't thought about this kind of new social media age and the engagement that people have with research now that they definitely didn't have at the time of Courage. And we didn't really think about kind of, the lay media and the implications of your results on a much wider audience. So, now I can kind of look back and think sort of see why things turned out the way they did, but it was all a bit unexpected at the time.
Wow. So let me, I'll start with an anecdote, and then I'll ask you more about what you do in your clinical practice. I sort of know, because I've sort of listened to other talks which happened, following ORBITA, but because we have you on the show, I'll ask you the question for the listenership. So the anecdote is the ORBITA. The story I think was covered in the New York Times, and I remember this was while I was at my former institution. I would do procedures in the cath lab on a Thursday, and I think the story in the New York Times came out on Wednesday. And I remember my secretary getting a phone call from one of my patients in whom I'd planned a revascularization procedure, PCI. And this patient was still having Canadian cardiovascular system class 2 angina on maximal anti-anginal therapy, as maximally tolerated by the patient. And the patient, had questions about why he should get the stent. So he ended up canceling that procedure. And I, sort of requested him to come back and see me in clinic, and maybe we could have a detailed conversation about the findings of the ORBITA trial. Which leads me to my question to you is, how has ORBITA changed your practice, in light of what was already known following publication of Courage, which basically told us that PCI does not lead to a mortality benefit or prevents future events from occurring. ORBITA sort of took it a step further in demonstrating, at least for a very short duration of follow-up, that it may be questionable that PCI would improve symptoms. How does ORBITA change your practice?
So, obviously the results of ORBITA have been discussed kind of to death. I always find it really interesting because people tell me, their patients have come to them and talked to them about the ORBITA trial. And predominantly, I think that has been in the US, where obviously the media coverage was really quite startling. In the UK, I must admit, I can't even think of more than 2 patients that have ever discussed ORBITA with me. And I think that's probably because they've kind of Googled me ahead of seeing me in the clinic, as opposed to having heard about the result in our media. But in terms of how it changes what I do, well, firstly, I don't believe the trial is absolutely perfect. No trial is perfect, and there are obviously limitations, and we're now conducting ORBITA 2. But I do think actually we've learned some quite important aspects from ORBITA. One is that I think we have to think about symptoms very carefully. The type of people we recruited in ORBITA, and, I say we because this was a big, group of investigators, many of whom are very, very good friends of mine, throughout the south of England, who had basically referred patients who were essentially on clinical waiting list or about to be referred onto clinical waiting list for angioplasty. They were your normal standard patients who had presented with a range of symptoms, some of which were absolutely classical typical angina symptoms, and others might be angina equivalent symptoms like restlessness on exertion or something that you may attribute to their epicardial coronary disease. They, in the main, had very severe angiographic coronary disease, and 94% of them had an ischemic test that was positive. And so these are people waiting for stents, and then you randomize them to have placebo or a stent, and we suddenly found, a much smaller difference between the 2 groups in terms of exercise time and symptoms than we'd expected. And now I think that's maybe because there are lots of symptoms out there that are not caused by their epicardial disease, and potentially those patients stand obviously to benefit less from treatment of their epicardial disease. But when we see the angiographic stenosis, we attribute everything to that. I also think that actually the link between ischemia and symptoms is quite a lot less straightforward and linear than we might have expected. And we're learning that from our subsequent papers. So now what I do when I see a patient with stable coronary artery disease is, firstly, I really think about those symptoms, and I think about whether those symptoms are going to be potentially treated by angioplasty. I also think about their ischemic burden, and I still believe potentially that those people with more ischemia may benefit more, and we certainly saw that in the second paper, that ischemia benefit is greatest in those patients who have much lower ischemic burden on FFR or IFR in the cath lab. And so but what I also think is, once I decide to put in the stent and perform the PCI, I've got to deliver an element of placebo, because there is some placebo component to what we do. So if I show them the images and show them how much better that angiographic disease looks because of the stent and how the arteries are now normalised, I also kind of counsel them as to the fact that not all of their symptoms may go away, but these are the symptoms I expect to go away. I hope that they're less likely to come back. But in essence, I do find that I'm a bit more conservative now. So the types of mid-circumflex lesions that I was potentially stenting a few years ago, I probably don't do as much of that now. Whereas the very tight proximal LADs in 50-year-old patients who don't want to have anti-anginal therapy for the rest of their lives, those are still people I'm stenting. In the hope that, there's a trial somewhere that shows some benefit.
Yeah, wow. No,
I don't know. I mean, it's a complicated disease, and I don't think it's got a straightforward answer, really.
Yes, I mean, so the reason I wowed was the description that you gave about the nonlinear relationship between our perception of ischemia and its relationship with symptoms. And, I think the follow-up paper, correct me if I'm wrong, but was this follow-up paper published in JAMA Internal Medicine?
No, it's published in Speculation. And,
yes.
And basically what we did there was we took patients. So we always plan to do a series of analysis, and I'll tell you about this analysis and also an upcoming analysis which will be published in a few weeks' time. So what we did was all of the patients in ORBITA, the vast majority, had IFR and FFR measured in the cath lab, but as you might remember, the physicians were blinded to those results. Mm-hmm. And that was because, in reality, what we were trying to look for, we presumed PCI would definitely have an overriding benefit over placebo, but that what we could do next was try and find a cut point for angina relief based on FFR and IFR, and it for the first time in a blinded trial. So in order to find that cut point, we needed to be able to recruit a range of patients. And so what we then did in the secondary analysis was we stratified patients based on their IFR and FFR, and we saw the relationship to the various endpoints of ORBITA based on their pre-randomization FFR or IFR. And the only tight relationship that we found was that the lower your FFR and IFR, the greater the placebo-controlled improvement you would have in stress echo ischemia in the PCI arm. So there was a tight relationship between one ischemic metric and another ischemic metric, or another test for ischemia. But then we found no relationship between the baseline FFR and IFR and the placebo-controlled improvement or change in exercise time or any of the symptom endpoints. And that might be because we were underpowered, because of course the effect size was so small on any of those endpoints in the primary paper. It might also be because there's not such a tight link between ischemia and symptoms and exercise time. And in fact, what we're presenting next, and I'll be presenting at AHA, in fact, also with a simultaneous publication in Circulation in a couple of weeks' time, is the stress echo stratified analysis. So this time we'll take again the same group of patients, we'll look at their pre-randomization stress echo data and see whether stratification based on VSE ischemia will again bear any relationship to their endpoints in ORBITA, which is kind of interesting because it relates to the Ischemia Trial, which will actually be presented the same day. And obviously the results are embargoed at the moment, so I can't tell you anything about our paper, but you'll find the results in a few weeks' time.
Sure. Which actually I think is a great segue to have you talk about the Ischemia Trial. It's obviously been discussed and talked about and has been touted to be the trial that may change how we practice cardiology, how we practice modern cardiology, how we revascularize stable ischemic heart disease. So talk to our audience a little bit about the Ischemia Trial and what you anticipate the results to be. The podcast will be broadcast after the Ischemia results have been published. Obviously, I don't want you to break embargo and have this conversation with me here because, we're still recording before the results of the Ischemia trials have been presented and published. But, talk to the audience a little bit about the genesis of ischemia, how you think ischemia is important, and what you anticipate the results to be in light of what you've already found in your patients with ORBITA.
Yeah, so interestingly, I'm one of the co-moderators on the session for the ischemia late breaker, and in fact, I still don't know the results. So that there's no, I am just guessing when I kind of talk about the results.
Sure.
But I think ischemia is very, an incredibly anticipated trial because on the basis of courage, there were a number of unanswered questions, and obviously at the time, many people said, "Well, does this change our practice? Does courage change our practice?" And there were lots of people speaking to the perceived limitations of courage and why another trial was needed. Now, obviously, it's been an incredible undertaking for those investigators. Recruiting over 5,000 patients in over 35 countries all over the world obviously has been a major feat. So they are to be congratulated for that for sure. It has also been an incredibly expensive trial, and many people have talked to the fact that it cost over $100 million. And so it is important for us to really think about the results. I think predominantly because if we don't think about the results of such an expensive trial with so many patients recruited, or if we just dismiss the results if we don't like the answer, then it kind of puts into question why we practice evidence-based medicine. What's the point of doing all of these trials if we're not going to listen to the results? They can't just be used as a mechanism to promote the investigators or to promote institutions. It's important that we think about what they mean. Now, I think there were some parts of that design that were, the ischemia design, that are just, are great. The fact that they tried to work out whether there is a relationship between ischemia, revascularization, and hard endpoint was courageous and exactly what we need to know, because there isn't, all the data that's out there at the moment is observational and doesn't really tell us if there's a strict link. I think it was great that they recruit patients with moderate or severe ischemia. They then have a blinded CT, so they are randomized prior to anyone knowing anything further about their anatomy. And of course, in the invasive strategy, they have a cath, and the conservative strategy, they have no further cath. And hopefully that means that they obviously exclude the left main lesions, but that people aren't suddenly not randomizing patients with tight proximal LAD lesions or lesions in epicardial vessels. And many people said that in courage, those patients were excluded. In fact, when you speak to the courage investigators, they say actually many of those patients did make it into the trial. But in any case, I think having randomization prior to cath is a very, very good strategy. And of course, the endpoints of the trial were initially said to be, there was a composite endpoint for which they got their funding. Then I think they very ambitiously said that the endpoint would just be death and MI. And you probably read a paper that I was a co-author on, discussing the issues with maybe changing the endpoint over time, not so much changing it, but going back to their original 5 composite endpoint with resuscitated cardiac arrest, hospitalization for unstable angina, and heart failure. And I think that particularly those hospitalization endpoints are subject to issues because of unblinding, and they may potentially be biased and may change the results. In terms of the results, I think it has taken them such a long time to recruit. They obviously initially planned to recruit even more than over 5,000 patients when they were recruited. And obviously, to be powered for death and MI, they needed many more patients than 5,000. And so I think it will be interesting. I think it will be unlikely that we will see a difference in terms of the hard endpoints, death and MI, between revascularization and the conservative arm. But, of course, I stand to be corrected. On the quality of life endpoints, things like symptoms, and I think it's possible that we might find that the invasive strategy shows a difference. I might caution how we interpret that, because, of course, this is an unblinded trial, and, obviously I feel that for subjective endpoints, we need blinded trials with placebo control to really know the answer. And then it'll be interesting to see what happens with the CKD presentation, which is, of course, a different cohort for whom, these patients have very high risk profiles and are much more likely to have, I would have thought, more likely to have a difference between the invasive arm and the conservative arm. But again, we'll see. And I think it really depends whether they recruited the right kind of patients and whether the angioplasty or the revascularization, by whichever form, was done correctly. I think also the medical therapy will have a massive impact on the results. They've already presented the baseline data there, and we can see that obviously there had to be modifications in terms of how ischemia was analysed. They planned initially for that to all be done by the core lab, but in the end, some centres did that themselves and then had it adjudicated by the core lab. I wonder what difference that might make to the results. I don't know. I suspect that the results will be very nuanced, with, a kind of grey result rather than a sort of slam dunk one way or the other. But we'll see. I don't know.
Sure. So I'm going to run 3 specific clinical scenarios by you, and see how you would take care of these patients. These are hypothetical patients, but obviously patients that you and I see in our clinics, in our daily practice. So one is a patient, a gentleman in his mid-40s. He's has the traditional cardiovascular risk factors, essential hypertension, diabetes mellitus, diabetic dyslipidemia. He has been having symptoms of exertional intolerance and angina. And the primary care physician, or the GP, if you will, obtained a stress test, a stress echocardiogram, which showed that there was evidence for inducible ischemia in the territory of the left circumflex. So this gentleman has now been referred to see a cardiologist, a consultant cardiologist like you and I, and comes to see us in our clinic and has not been initiated on anti-anginal therapy. Just takes a baby aspirin, takes a statin, high-intensity statin. How would you approach this patient? Would you, assuming these are stable anginal symptoms and not there's no evidence for unstable angina, how do you manage this patient in the office, and what triggers a visit to the cath lab?
So these days what I do is, I must admit, I am quite a lot more thoughtful about anti-anginal medication. So I saw in ORBITA, just even as we were recruiting, some of the unbelievable symptomatic improvements that we had just with anti-anginal therapy. Of course, some of those anti-anginal therapies have got significant side effects, and a 40-year-old man may not want to take beta blockers or nitrate for the rest of his life. But with these patients at the moment, what I'm doing is introducing anti-anginal therapy, and predominantly, if I have evidence of ischemia, bringing them to the cath lab. The reason being, and perhaps the research isn't there to back this up, but I still believe that if patients have a high burden of ischemia, then there is likely to be a relationship with their long-term outcomes and their risk. The difficulty I have is that we haven't seen from any prospective trials that that's necessarily related. So, I may have to change that thought process once I see the results of ischemia. The other issue that I have is a 40-year-old man usually wants the problem, what they perceive, to be fixed. Mm-hmm. They don't necessarily tolerate the fact that you're going to leave them walking around with this lesion that's not got any better. Now, you kind of present me with a circumflex lesion, and very rarely do we see events that are circumflex. Many would argue it's not really prognostic. But if I had an ischemia on a stress echo, I'd want to know if it was a very big dominant circ with a kind of, hardly existent right coronary artery system. And so I probably would bring them to cath lab. I probably would want more evidence for ischemia, so I'll probably do invasive physiology, and then I'd work out what I want to do. Difficulty with a man like that is, say he becomes asymptomatic on medical therapy, do I do nothing more? At the moment, many of those patients I'm still stenting because I say maybe I'm doing it for more than just symptomatic relief. But I might have to change what I think after I see the results of ischemia.
Sure. And, would that response or answer change if I were to say the ischemia was in the territory of, say, the right coronary or the left anterior descending?
I think when it's I think predominantly for the LAD, I still believe that those young patients with tight proximal LAD probably stand to gain the most from revascularization than anyone else. Mm-hmm. Again, I haven't got the data there, but that's still my current belief that, I think where it might change, and maybe that's what you're about to come to next, is if you tell me that the age of this patient is something very different. If you now say this patient was 85 years old, mm-hmm. then I might think differently about this patient, if I'm honest. I might think, is there really a prognostic benefit to revascularization? Not so much. And can I restore their quality of life and reduce their symptom burden by just the anti-anginal therapy without necessarily exposing them to a risk of a procedure? And then I do change my therapy, actually. Now, I'm not being ageist about it, but, I think about other stuff, comorbidity, is this patient potentially, housebound? Are they, all these other things that come into play as our patients get more elderly? Mm-hmm. I'm going to think about all of that.
Sure. And then, one final scenario, and then, that'll be, I think, the conclusion to what I think has been a fascinating podcast. And again, Rasha, thank you so much for your time. And that is, what do you do with patients who get the heart scan, which, is, you and I know it's the coronary artery calcium scan for, prevention or for preventative purposes, and find out that their coronary calcium score is high? Certainly, at least the appropriate use criteria guidelines in the U.S. state that if it's over 400, it's appropriate to then take these patients to the cath lab. But how are you managing abnormal coronary artery calcium scan scores? What do you do with these patients? Because they're otherwise totally asymptomatic. They're totally quote unquote healthy, and are exercising, living vital lives. And then, a friend recommends them, hey, why don't you get this heart scan? It's supposed to tell you whether you have heart disease, in very lay terms. And lo and behold, they land up with these coronary artery calcium scores, which are in the 400s, 500s range. How are you managing these patients?
So, I'll tell you, this speaks to the difference between your healthcare system and ours. Those patients really don't make it. This just doesn't happen in the NHS. It really doesn't. It might happen occasionally in our private healthcare system, but in the UK, that element of looking for disease you don't have yet or haven't presented with yet just kind of doesn't exist. Mm-hmm. So we don't do calcium scores certainly not as a routine, and certainly not as a kind of screening tool. If a patient has a CT with me in the NHS, they'll be having that CT for more than just their calcium score, also for the anatomy, and it will be triggered by symptoms or, a reason for me to believe that they may have had an event or something in the past. So I wouldn't be screening these asymptomatic patients. And if I, kind of now put myself in your shoes and I have an asymptomatic patient who came with a score like this, I don't think there's an evidence out there for us now taking that patient to cath. Mm-hmm. At a kind of halfway house, obviously I'd be considering risk prevention medication as standard for those patients, and obviously that, starting on a statin, etc., and thinking about what else I need to change in terms of that risk. But if I really needed to do something, I'd probably do an ischemic test, because the only reason to even consider revascularizing that patient would be if you still believe that we need to reduce their ischemic burden, I think. And so therefore I'd want evidence that they have ischemia. And I would rely on a non-invasive test rather than putting them through the risk of an invasive test for that. But, I think that practice of medicine is very different in a publicly funded healthcare system versus a privately funded healthcare system. And, I don't know what you think of that, but I think, the incentives in a public healthcare system to do such tests, well, there aren't any really. And, it would overburden our whole system to start doing screening tests in that way. And I'm not sure that there's a benefit for the patients for doing it.
Yes. I agree with you that...
that's controversial perhaps, but...
Yeah, no, it does. It does. Thank you for your candor and a very honest answer. I struggle with these subset of patients. Now that even aspirin in primary prevention has shown to not be of benefit, I think the only medication that we're left with is high-intensity statin therapy in patients who have coronary artery calcium. But I honestly struggle with these patients quite a bit. And I don't necessarily know what the right answer is. I try and not taking these patients to the cath lab because, like you said, the evidence is skim to begin with. Certainly, if they haven't had an ischemic evaluation with a selective invasive strategy with a stress test, as a gatekeeper to being in the cath lab. But I think ischemia is going to tell us a lot more. As well as your paper, which is going to get published in about a couple of weeks. So once again, Rasha, congratulations on advancing the field and all that you've done on educating us about how we should take care of patients with stable ischemic heart disease. Again, it's been our honor and pleasure having you. From the entire team at Parallax. Thank you, and we wish you all the best.
Thank you very much. It's been great. Thank you so much.
Yeah. All right. Bye-bye.
Take care. Bye-bye.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.